So hi, I'm Emily. I'm one of the final year medical students, currently at Basildon Hospital. And today I'm going to be presenting to you urology, GUM, and HIV medicine. So we'll kind of break it up into three categories. We'll be starting with urology first, and then we'll move on to kind of GUM, sexual health, and then finally HIV. So as we can see here, there's a wide range of topics we're going to cover today. Just giving kind of a general overview of each one. And yeah, so we'll start with urology firstly. So we can break urology down into each individual kind of organ. So we'll start with kidney. So the two key things that we'll be looking at with the kidney is renal tract calculi and pyelonephritis. We'll then move on to the bladder. So the two key things is kind of the cancers that occur in the bladder and that kind of tract and incontinence. With the prostate, we'll talk about BPH, prostate cancer, and acute urinary retention. The genital tract, we'll talk about epididymitis, testicular torsion, and testicular cancer. And then finally, we'll talk about this other category, which is more kind of issues to do with the penis. So balanitis, phimosis, and paraphimosis. So if we look at the kidney and renal tract firstly, we have a little SBA for you guys first. So there's a 70-year-old man undergoing chemotherapy, develops renal colic and hematuria, no stones are seen on imaging. What is the most likely type of renal stone in this scenario? So if you want to pop your answers in the chat. Okay, so if you have a look at our answers now. So the correct answer is D. So when people are undergoing chemotherapy, what happens is the chemotherapy is kind of breaking up kind of the bulk of the tumor, it's targeting the tumor, and that's causing a lot of kind of tumor cell lysis. And when that happens, a lot of uric acid is released into the bloodstream. So that can go and kind of set up camp in the joints, and that can cause gout, or it can go and set up camp essentially in the kidneys, and then it'll create these renal stones which have uric acid kind of in them. And these tend to be radiolucent. So when we scan for these, we don't tend to be able to pick them up. But based on kind of the history and the presenting symptoms, we can kind of have a good idea that this is going to be kind of a uric acid stone. The most common type of stone is calcium oxalate. So if a patient presents to emergency department with kind of colic, hematuria, kind of loin to groin pain, then you're going to be thinking, your first kind of thing you'll be thinking is a calcium oxalate stone. And then there's these kind of rarer stones, which are very kind of large, and they kind of form the shape of what the renal pelvis looks like, and they're called staghorn calculi. So as we've just gone through, calcium oxalate is the most common, but you can also have calcium phosphate stones. The struvite ones are the ones that form the staghorn calculi, which we can see here. It essentially builds up within the renal pelvis, and they take the shape of the renal pelvis. We can have the urate stones, which are more common when we've got a malignancy, or if you have someone that has a high kind of uric acid diet. So someone who eats a lot of red meat, for example, drinks a lot of kind of alcohol. And cystine stones. So cystine stones are associated with people who struggle to kind of get rid of their to get into their cystine into their body. And so because of that, we essentially get lots of stones, which we call cystine stones. We can then classify stones based on where they are in kind of the renal tract. So we have our staghorn calculi that sit within the renal pelvis. We can then call them pelvic stones if they're sat in the renal pelvis, mid-ureteral stones, or bladder stones if they sit in the bladder. So there's a lot of different risk factors for renal tract calculi. The main one being dehydration. You can also have them if you have high calcium. So if we think about our stones, abdominal groans, psychiatric overtones, all those kind of things, it would make sense that we have a renal stone. If we also have conditions such as renal tubular acidosis, we're at an increased risk. And then there's different risks depending on what type of each different stone. So if you've got gout or an ileostomy, you're at high risk of the uvate stones. If you're on loop diuretics or steroids, you're at more risk of calcium stones. And so renal stones tend to present mainly with colic. The colic will only occur if they're obstructing the passage of urine. So if the stones kind of sat in the kidney, not really obstructing anything, not really doing anything, they won't be causing the colicky pain. It's only when they go and block the outflow is when we get colicky symptoms. So it'll be severe on and off kind of griping pain from kind of loin to groin, so from the flank to the pelvis. You can get a little bit of hematuria with it. It tends to be non-visible, and the pain can be so severe as well that it causes some nausea and vomiting. So, if that then gets infected, so the kidney gets obstructed, and there's a little bit of bacteria which has nowhere to go because the kidney is obstructed, it'll essentially cause an infection in that area. So then you get the typical infection kind of symptoms such as rigors, fever, lethargy. So if you examine the patient, they'll be kind of rolling about in pain, struggling to kind of stay still because of this colicky pain. And they'll be really tender when you press on the affected kidney. So whenever you are thinking about renal tract calculi, you can also be thinking about pyelonephritis because they'll cause a similar set of symptoms, especially if it's infected as well. So if you've got an infected kind of renal tract, infected kind of kidney with a renal tract calculi, you'll get a very similar set of symptoms to pyelonephritis. With women, you have to think about any gynecological pathology, such as an ectopic pregnancy, or ovarian torsion. And then you also have to think what's also in that area. So in that area, we've got some bowel, so it could be that there's a bowel obstruction. We've got, if it's on the right side, we've got our biliary tree sat there. And also our lower lobe of our lung can come down, and because if you've got a lower lobe pneumonia, the infection that's there can actually cause pain that is in the kind of the upper quadrant of the abdomen. So we have a 30-year-old woman who presents to A&E with severe flank pain. She's systemically well. The CT KUB shows a simple 4 mil ureteric stone, no hydronephrosis. What's the most appropriate management? If you stick your answer in the comments. Okay, so if we have a look at our answer. So yeah, watch and wait. We've got a very small stone sat in the ureter. There's no infection because she's systemically well. There's no renal impairment because she's got no hydronephrosis. We can watch and wait because it's under 5 mil. We can see if this woman's gonna pass it herself. So we don't need to do anything kind of invasive to help that along at this point in time. So the way we investigate renal tract calculi is we can firstly start with a urine dip, really important because we're going to look for any signs of infection, which might be pointing us more towards a pyelonephritis, and we're going to rule out pregnancy as well. So we might get some hematuria on the dip. Don't necessarily have to get hematuria on the dip to be thinking renal tract calculi though. We also want to be doing some bloods. So a full blood count and a CRP. Going to check the white cells and our inflammatory markers. We're going to be using these just to check renal function because we've made an assumption that because there's no hydronephrosis, that there's no renal impairment, but we just like to ensure. Urate and calcium levels to try and figure out what kind of stone it is and why this person's developed that kind of stone. If we're thinking we're going to have to do a procedure to remove the stone, we can also do clotting, we can also do a group and save. And if we think this person is systemically unwell and they may be becoming septic, then we consider cultures as well. Imaging for renal tract calculi, gold standard is a non-contrast CTKUB. This is if the person's kind of systemically well. We're not really worried about them kind of being in obstruction or infected. And then what we then do is we go to our management. So we initially want to manage their pain. So I think a really important kind of habit to get into, especially for OSCE world as well, is whenever a patient's presented in pain and you're doing an assessment, you always want to mention pain relief. So it's really important to consider pain relief here. Really good option is either PR or IM diclofenac. So you can, it most commonly is PR. So you'll give a diclofenac suppository. Give some fluids if they're dehydrated. And then we need to consider if there's any infection. So a situation that you worry about is the obstructed infected kidney. And so if we're thinking there's an obstructed infected kidney, we need to start them on some broad spectrum IV antibiotics. We can then decide what we want to do in terms of the kind of treatment, like the goal-oriented kind of treatment. So how we're going to relieve the blockage and long-term stop this occurring. So we're going to increase fluid intake and have a low salt diet for calcium stones. For uric acid stones, we're going to have allopurinol. So this is a nice kind of flow, kind of tree diagram for renal tract calculi. So the first thing you want to establish is, are we worried about the obstructed infected kidney? So if we are, that automatically becomes an emergency. And we have to insert, you usually do a percutaneous nephrostomy. So essentially it's just a tube that goes straight into the kidney through the skin. And the aim of that is to relieve kind of the obstruction and the kind of get some of the like pus that's kind of causing the pressure to build up in that kidney out. If there's no obstruction or infection, and we're happy that there's never been a transplant or anything like that, so any underlying kind of abnormalities, we can then go on size. So if it's under 5 mil, we're happy that we can do conservative management. If it's over 5 mil, if it's a really complex stone, so it's got kind of a weird kind of morphology to it, or if it's a staghorn vessel, so one of those really large stones that fills up the renal pelvis, then we'll have to do a percutaneous nephrolithotomy. So essentially we just take the stone out. If it's not one of these complex or staghorn vessels, stones, sorry. If they're not pregnant, we go straight for lithotripsy. So that's like shockwave treatment to try and break the stone up so it makes it easier to pass. If they are pregnant, then we do ureteroscopy, which essentially is we go in through to take the vessel out of the take the stone out of the ureter. Okay, so Next question is a 30-year-old woman presents to ED with a fever and 2-day history of dysuria. Today she has noticed back pain on the left side, shakes and cold sweats. What is the most likely diagnosis? Brilliant. So our answer is E. So this sounds like a classical presentation of an acute pyelonephritis. So they initially start with what seems to be kind of lower urinary tract infection symptoms. So kind of bit of fever, some lower abdominal pain, dysuria, increased frequency, increased urgency to pass urine, some offensive urine. If that's then um, either not treated or use of nitrofurantoin or trimethoprim doesn't really help it. It can track up the ureters into the kidney and cause an acute pyelonephritis. And so when the pyelonephritis takes hold, that's an upper urinary tract infection. And that's when you start to get some back pain, like higher fevers, rigors, cold sweats, kind of quite systemically unwell. With our UTI, so that would be more of our lower urinary tract symptoms. So that was our dysuria, lower abdominal pain, increased frequency and urgency. Doesn't really sound like renal colic because it's not this on and off pain. And she's quite systemically unwell, and she's got dysuria, which ureteric colic wouldn't cause. A pneumonia, she's got the kind of infective symptoms, but it wouldn't explain the dysuria. And ileopsoas abscess. So if this woman was an intravenous drug user, we could be thinking more about this, but we haven't been told that in the question stem. Therefore, it's the less likely of the two options. So pyelonephritis, we've just discussed how it initially starts. So it'll start with lower urinary tract infection and then progress upwards. Most commonly is E. coli. So E. coli is a kind of a natural kind of gut flora, which the urinary tract, most commonly in women, can get infected with, and it will track up and cause a UTI. And the first kind of thing to do is you want to do urinalysis. So because this tends to happen more in women than men because of the short urethra compared to men, so it's easier to get to the bladder. We do our urinalysis. We always include a pregnancy test just to be absolutely certain. And we're looking for kind of three things. We're looking for leukocytes, nitrites, and any hematuria. So nitrites produced in response to kind of bacteria. Nitrites are kind of the key indicator here that there's a bacterial infection. Leukocytes, non-specific, can be raised if you've got a UTI, can also be raised if you have like a urethritis, which is more of a sexual health kind of a presentation. If we think this person needs some antibiotics and we're worried that there may be resistance, or hasn't had a culture in the past and they've had recurrent infections, then we could consider a urine culture just so we know what we're targeting our antibiotics towards. We can do some bloods. So we want to do a full blood count again for the white count, CRP for inflammatory, using these to make sure that the renal function hasn't gone off because of this pyelonephritis. And we can also do some imaging. So we can do ultrasound just to check there's no obstruction, and a non-contrast CT KUB if we're thinking it could be more of a colicky kind of presentation. So we manage this as an A to E. We give fluids and antibiotics, analgesia, antiemetics. If we think that they're going to obstruction, we can catheterize, and we can check that there's no obstruction or abscess with a CT imaging. So always refer to your local guidelines for when you're looking at antibiotics. think microguide's probably the best one to go to when you're actually in the hospital. Yeah. So if we move on to the bladder now. So we have a 50-year-old man presenting with painless hematuria, past medical history. He's got hypertension, a schistosoma, hematobium infection, and an appendectomy about 30 years ago. What malignancy has he increased risk at developing? Brilliant. So B. So this when we think painless hematuria, our brain should kind of automatically go to a bladder slash urothelial cancer. And so that gives us three kind of key options. That gives us a TCC, an SCC, or an adenocarcinoma. TCC is the most common. Squamous cell is the kind of second most common and tends to occur when you have a past medical history of a schistosoma infection. And then adenocarcinomas and sarcomas are incredibly rare in the bladder. So, risk factors for bladder cancers and urothelium cancers are being male, smoking, having exposure to dyes and rubbers, any kind of radiation to the pelvis. And an important one to remember is cyclophosphamide. So cyclophosphamide is used for like immunosuppression, so it's and as a chemotherapy agent as well. So really important here. So we can classify it based on whether it invades into the muscle of the bladder, so the kind of deeper layers of the bladder. If it's muscle invasive, it means that it's a much more invasive cancer. And then if it locally advances, so it goes beyond the bladder into other organs in the pelvis or kind of distally. And so it can present as painless, it tends to present as painless hematuria, can also present as recurrent UTI and some lower urinary tract symptoms. So anyone 45 or over with unexplained visible hematuria, either without a UTI or after treatment of UTI, needs to be referred straight away. Over 60 or 60 plus, if they've got non-visible hematuria and either dysuria or raised white cell count on a blood test. So we dip the urine, we get hematuria. The gold standard for bladder cancer is a flexible cystoscopy. And then when we identify our tumor, we then go for a biopsy and we try to remove it. So the way we remove it tends to be a transurethral resection of a bladder tumor. But it's important to do a CT before we do a transurethral resection, just so we can see how deeply the tumor invades, and therefore if that procedure is appropriate or if we need to alter our management plan at all. So when we've got non-muscle invasive, we can just do the transurethral resection. But if it's deemed to be high risk, we can either kind of instill the bladder with BCG or mitomycin C, or we can do a radical cystectomy. If it's muscle invasive, we're going to have to do a radical cystectomy and make kind of a diversion for the urine as well. So via an ileoconduit or urostomy. Can also consider chemotherapy beforehand, so before doing the cystectomy to shrink the tumor. And then for locally advanced or metastatic, we're going to be considering kind of chemotherapy as kind of a non-curative approach. So we now have a 65-year-old woman with multiple episodes of sudden urge to pass urine and can't make it to the toilet on time, which only occurs certain times of the day, and the urinalysis is negative. What's the next step in management? So for this one, our answer is A. So whenever someone's coming in with kind of any type of incontinence symptoms, then we want to get them to do a bladder diary. So we want to see when it's happening, if it's any specific type of time of the day, what they were doing prior to it. Were they exercising? Did they cough, sneeze? Had they had caffeine? Anything like this. So as much information so we can try and figure out what type it is. So there's many different types of incontinence. The most common ones you'll see are stress, urge, and mixed. So stress is when there's a high intra-abdominal pressure, which essentially causes a leak through the urethra of urine. So when coughing, laughing, or lifting, exercising. Urge is when we have an overactive detrusor muscle. So we have a raise in the intravesical pressure because there's a lot of contraction in the bladder because of that overactive muscle causing the leakage. And then mixed is when we have a bit of both. We can have overflow, which is when we have chronic urinary retention. The bladder simply just can't hold anymore. And so there's leakage through the urethra to account for that massive kind of expansion of the bladder. And then the other one that you may see is functional. So that's simply when someone is struggling with maybe mobility or their house is kind of not an ideal setup for their mobility or ADLs, and therefore they struggle to make it to the bathroom. So the initial approach is you want to get a detailed history and get them to do the bladder diary. We can examine for any kind of signs as to why it's occurring. So we can look for an enlarged prostate, so anything like BPH. If there's a fistula, so if there's a fistula that's connecting the bladder to, I don't know, maybe the vagina, then to see if there's any leakage of urine that way. And if there's any prolapse, so more common in, well, if we're thinking of vaginal prolapse, it'll be kind of women who've had children and older women as well. So we can investigate by doing a urine dip just to check there's no infection, no hematuria, a post-void bladder scan to see what volume of urine sat in the bladder if we're thinking that there's overflow. We could do urodynamics, but it's not really done that often. What we tend to do is jump straight to management. So we essentially decide which one it is and then manage that accordingly. So for all, we want to reduce caffeine. We want to avoid drinking liquids, large volumes of liquids, especially towards the end of the day. Stop smoking. And then we've given the kind of management for the two key ones here, so stress and urge. So stress is more common in, stress incontinence is more common in women who've had children, postmenopausal women, obese women, but it can occur for both. We essentially initially start with pelvic floor muscle training. So we're trying to strengthen the pelvic floor. The reason for this is so that the bladder is not kind of slipping below the pelvic floor, and that can cause kind of pressure on the bladder, which causes the incontinence. If that fails, then we can move on to using duloxetine, because that's going to cause stronger kind of urethral contractions and prevent the urine from leaking out. If that then fails, or the person would prefer not to have medicine, then you can go to surgical. So in women, we can do tension-free vaginal tape. So it essentially holds the bladder up kind of above the pelvic floors. Or we can do debulking, or we can do a corporal suspension, which is kind of the open version of kind of the tension-free vaginal tape. But urge incontinence, more common if you've got an infection or a neurological condition, or if you're on cholinesterase inhibitors. What we try firstly is bladder retraining. If that fails, we then move to our antimuscarinics, so oxybutynin, tolterodine, or darafenacin. The antimuscarinics have a very high kind of anticholinergic effect, which can be an issue for elderly people or people with reduced mobility. And so if that is the case, then we'd go for something more like mirabegron, which is a beta-3 agonist instead. That fails, we can then do things like botulinum injections or nerve stimulation. We then move on to looking at the prostate. So our two key conditions here are BPH and prostate cancer. So we have a 60-year-old man presenting to clinic with formal history of nocturia, weak flow, intermittent stream, terminal dribbling. Past medical history is unremarkable. Digital rectal exam, smooth and large prostate, trace protein in the urine. What is the most likely diagnosis? Great. So our answer here is E. So this person has a lot of lower urinary tract symptoms, which is very in keeping with BPH, as his prostate. So his prostate was kind of globally enlarged, but smooth. So BPH, essentially what happens is in the transitional or central zone of the prostate, we have enlargement, so hyperplasia. The reason for that is we initially have a testosterone surge in puberty, and that causes the increase in cell number. And so we have hyperplasia of the prostate, which persists into old age, and that can therefore cause kind of impingement on the urethra. So you'll get kind of low urinary tract symptoms, and we can split these into storage and voiding. So storage symptoms tend to be increased frequency and urgency, nocturia, urge incontinence. So these are all issues with kind of keeping the urine in the bladder. The other one is voiding. So voiding is everything to do with when we're trying to pass urine. So hesitancy, weak stream, terminal dribbling, incomplete emptying, second voiding. So we can do a full history, thinking about any other past medical history this person might have. We can do a digital rectal exam, and it should be symmetrical, it should be smooth, it'll be enlarged, but you'll be able to feel the kind of sulcus in the middle between the two lobes. So we can get them to, similar to like a bladder diary, we can get them to do a diary on how often they're passing urine and what volume they're passing. We can also rule out a UTI through a urine dip. If we worry about a prostate cancer here, so if our digital rectal exam didn't really feel symmetrical, smooth, then we could do a PSA. And we also want to do USNE, just check the renal function is okay. The main issue with BPH is it can cause retention, so it can be acute, which can then lead to an AKI, or it can be chronic, which can lead to a lot of UTIs and bladder storms as well. So similar to our incontinence stuff, we adjust our fluid intake and reduce caffeine and alcohol. And then we move to medical options. So we can use something called tamsulosin, which relaxes the smooth muscle, or we can use finasteride. We use this if they're at a high risk of progression. Can use these both together as well. Or we can use an anticholinergic, such as oxybutynin. If this isn't tolerated or the person doesn't want to take medicines, we then move to a TURP. So that is removal or resection of the prostate. There are a few complications to know about this. The retrograde ejaculation, for example, so ejaculating inwards rather than outwards, hemorrhage, and TERP syndrome, which causes fluid overload and hyponatremia, but very rare post-surgery. For prostate cancer, they're always consider the risk factors, so BRCA mutations, smoking, Black ethnicity or family history of prostate cancer, and obviously age. As we get older, the risk increases. So you can get some low in your urinary tract symptoms, but it tends to lie dormant and asymptomatic for a very long time. As it advances, we can then get hematuria, hematospermia, some pain in the loins, and then when it spreads and becomes metastatic, you can get bone pain, your typical kind of B symptoms, so anorexia, lethargy, weight loss. So you'll do a digital rectal exam and it'll feel craggy, irregular, fixed mass, asymmetrical. PSA you'll do, it can be high, might not be high. It all depends. You have to take it in context. So if they've had prostatitis, they've cycled recently, ejaculated recently, then you have to take that PSA in context because it can be artificially high. Gold standard is a multi-parametric MRI, and that is how it tends to be diagnosed nowadays. And we can grade and essentially using a Gleason score. So that essentially looks at how the morphology is of a biopsy under the microscope. So one being small uniform glands, nice and well differentiated, will probably be either a less aggressive cancer or a very slow growing cancer. And then as we get down to kind of 4 and 5, the morphology is lost, more aggressive cancer, or it's been there longer. We can also use TNM, which is our kind of our usual cancer staging system. Essentially looking at the size of it and where it is, nodal involvement and metastatic disease. So if it's localized, there's some options such as conservative management. If we think this isn't really going to move anywhere, then we can leave it well alone, watch and wait until the PSA rises or it starts to feel larger on digital rectal. Or if the person would prefer just to have it straight out, then we can move to a radical prostatectomy. And we can also deliver some radiotherapy either by external beam or brachytherapy, which is where we essentially plant these seeds of radioactive material within the prostate. If it's advanced, then we are moving to something like a hormonal therapy or radiotherapy as well. If it's metastatic, then we're going to have to use systemic agents for hormonal therapy. So first line is typically goserelin, which is a GnRH agonist or antagonist. You can also use antagonists as well. If it's kind of testosterone resistant, so essentially hormone therapy is not going to touch it, docetaxel is kind of first line for that. Next question. 70-year-old mom presents to ED with 10 out of 10 severe period pain a week after starting amitriptyline. Feels as though he needs to pass urine but isn't able to do so. What's the most appropriate management? Brilliant. Yeah, so our answer here is E. So this person is clearly in retention. Most likely due to recently starting amitriptyline in an elderly man. And the key thing to do here is to relieve the blockage. It'll sort his symptoms out and then you can figure the rest out afterwards. You just want to make him more comfortable, and urethral catheterization is the way to do that. So there's lots of different reasons people go into acute urinary retention. It can be due to BPH or any strictures or calculi, medicines, so as we saw there, anticholinergics, tricyclics, antidepressants. Can be neurological causes, though these tend to be more chronic, and any like UTI postpartum. So the symptoms, the key one will be unable to pass urine as the pressure kind of builds up in the bladder, get some lower abdominal pain and discomfort, can cause confusion in the elderly. So I actually saw a patient a couple of weeks ago who was in retention, and his only presenting complaint was confusion. And they'll have a palpable bladder, which will be painful on palpation. on examination. You can also do a rectal neurological examination and a pelvic examination specifically in women, just to check for any specific causes that we can identify. So you'll do urinalysis and cultures to check there's no infection, using these for blood count CRP, just to check there's no, again, no infection, and just to check that the renal function hasn't gone off due to back pressure. And a post-void bladder scan, just to check the volume of the bladder to make sure it's not a chronic retention. We can do an ultrasound to check for any hydronephrosis as well, which would be kind of as a consequence of the back pressure from the bladder into the kidneys. So we catheterize them. If the volume is under 200 cc's, it means they don't have retention. If it's over 400, if it's over 300, it means that it's retention. If it's over 400, we need to keep the catheter there until we kind of figure out what the next steps are going to be. If there's no renal impairment, we can trial them without catheter after the insertion, about 24 to 48 hours. If it fails multiple times, then we have to go to a long-term catheter, which obviously isn't ideal because of the increased risk of infection with this, and they'll kind of need long-term follow-up as well as investigation for the cause. So if we move on to our genital tract conditions now, epididymitis, testicular torsion, testicular cancer. So we have a 14-year-old boy, who presents to ED with sudden onset severe back pain in his lower abdomen and scrotum, which started 2 hours ago after being hit by a cricket ball. He's had previous episodes of scrotal pain, been less severe and self-resolved. On examination, his scrotum is tender, swollen, left testicle is higher than the right. What is the most appropriate next step? Brilliant. So we're going to contact urology. So the past history of trauma, the previous episodes of self-resolving severe pain, and the left testicle sitting higher than the right and being tender and swollen, it all kind of screams torsion. And so with torsion, you don't go for ultrasound, you just go straight for surgery, because for every kind of, it's essentially time really matters with torsion. If you waste time doing the ultrasound, it's time in which the testicle could be kind of necrosing, which is bad kind of for long-term outcomes. So oh, I think it's the wrong way around here. There we go. So testicular torsion. So we have the testy essentially rotating around the spermatic cord, which cuts off its own arterial and venous flow, and then that causes edema, infarction, necrosis. More common if you've got something called a bell clapper deformity. So the testicle's not kind of correctly attached to the tunica vaginalis, so it's more mobile and kind of sits more horizontally in the scrotum. More common in younger men, so kind of 12 to 25. Family history of undescended testes, or undescended testes in itself. It'll be kind of sudden onset, severe unilateral testicular pain. So it'll come on straight away and it'll be incredibly intense. It can refer to the abdomen as well, and it'll be so severe that it'll often cause nausea and vomiting. So you'll do a testicular examination, and it'll tend to be that the affected testy sits higher on the affected side. It'll be very swollen, it'll be hard on palpation and tender. The cremasteric reflex, so essentially where you kind of stroke the inner thigh upwards, will be negative, so the testy won't elevate. And Pren's sign will be negative, so you'll lift the scrotum up and it won't relieve the pain. So we're thinking it's definitely torsion here. So we go straight for surgical exploration. We don't do an ultrasound unless it's a very atypical presentation. will, in the surgical exploration, if it is torsion, they'll untwist the testy, see if it's infarcted and necrosed or not. If they're happy with the function of it, then they will fix the testy and then fix the other one as well. Because if you've got the bell clapper deformity on one side, you'll have it on the other as well. Okay. If we also talk about epididymitis here as well. So, epididymitis is inflammation of the epididymis. The epididymis kind of sits above and lateral to each individual testy. And what can happen is we can get inflammation of this. So it tends to be from infection, so it can be UTI or STI. If it's a male under the age of kind of 35, we're thinking more STI. Over 35, we're thinking more of an E. coli infection, like coming from the urinary tract. So with this, you will get, similar to torsion, unilateral scrotal pain and swelling. Unlike torsion, you can get fevers and rigor. On examination, it'll be swollen and red on one side. It'll be tender on palpation of the epididymis especially. The cremasteric reflex will be intact. So when you stroke the inner thigh upwards, you'll get a raising of the testicle. So that essentially, in your mind, ensures that it's not torsion. And Prensign will be positive. So if you elevate the scrotum, the pain gets relieved. But that's not the most reliable test. It's just an indicator. So if you're thinking it's a UTI origin, you can do a urine dip. If you're thinking it's an STI, you test based on which STI you're thinking it is. So for example, an NAAT, first void urine. So that would look for gonorrhea, chlamydia, and mycoplasma genitalium, which we'll cover later. We can also do bloods to see if there's any systemically signs of infection, and imaging, so a Doppler to confirm. So supportive management initially, so analgesia, bed rest, good scrotal support, advising to wear good supportive underwear or a strap, refraining from sexual activity, and giving antibiotics depending on what the infection is. If it's an STI, you treat based on which STI it is. If it's an enteric organism, so like an E. coli coming from the urinary tract, then ofloxacin or levofloxacin. So if we move on to testicular cancer now, so testicular cancer, we can separate into whether it's germ cell or non-germ cell. So germ cells are much more common and more likely to be malignant as well. So we can then split it into whether it's a seminoma or a non-seminoma. So seminoma will stay localized and grow localized for a really long time, and because of that, they have a really good prognosis. You remove the testicle, you get rid of the cancer. Non-seminoma, harder to treat, spread earlier, and these are all the different subtypes that you can have. Risk factors for this are undescended testes, or having testes that will and remaining undescended, or testes which are undescended which were then brought down during childhood. Family history, mumps orchitis, because of the kind of chronic inflammation in that area as well. So you can get a unilateral painless lump, which will feel firm, fixed, won't transluminate. If you get a hydrocele in a male, like an adult male as well, then you're kind of worrying about an underlying testicular cancer. Because these are all very kind of hormonal cancers, you can get some gynecomastia as well, more common in your germ cell and Leydig tumours. And when you metastasizes, you get your kind of general symptoms, your B symptoms, plus any bone pain, back pain, dyspnea if it goes to the lungs as well. You can get localized lymphadenopathy as well, depending on where it metastasizes to, commonly the para-aortic lymph nodes. So initially you do an ultrasound of the scrotum, and then you do your tumor markers. So there's 3 key ones in testicular cancer. There's beta HCG, AFP, and LDH. So depending on which one's raised, it kind of gives you more of an indication of which type of cancer you're thinking it is. And then you do CT contrast with staging and use the TNM staging system. Important to say you don't do a biopsy in testicular cancer because it can cause seeding in the other testicle or kind of further up. So testicular cancer tends to be that you'll need a radical orchidectomy, and then depending on what stage it is and the subtype, kind of dictates whether you'll then need any chemo or radiotherapy. So we'll go on to our kind of other conditions. So these kind of non-specific scrotal swelling, balanitis, phimosis, paraphimosis, so more of our penile conditions. So we have a 35-year-old man presenting to the GP with a 2-day history of scrotal swelling after being hit by a football. Examination, the scrotum is tense, swollen, difficult to palpate the testes, and swelling transluminates with a pen torch. What do we think it is? Brilliant. Yeah. So our answer is B. So the way we can kind of distinguish it being a hydrocele is the fact that it transluminates, which means it's fluid filled, which indicates hydrocele. And also we're struggling to palpate the testes separate from the swelling, which is another kind of hallmark of a hydrocele. So this is a good kind of flow diagram about scrotal swelling, so how to assess it. So we initially want to see if it's unilateral or bilateral. If it's bilateral, it can either be that there's edema or that we've got 2 pathologies occurring unilaterally, but that's unlikely. We can then decide if we can get above it or not. If we can't get above it, we're either thinking it's a hernia or a hydrocele, depending on whether it's transluminable or not. If we can get above it, if we can feel the testicle separate from the swelling, we then kind of look if it's translumable or not. If it is, we're thinking it's a cyst. If it's opaque, we're thinking it's either infection or tumor. If we can't feel it separately, then we're thinking it's hydrocele. If it's transluminable, if it's opaque, we're thinking torsion, hematocele, or a tumor. So some kind of key points for our scrotal swelling, which don't fit into our epididymitis or our torsion. So an inguinal hernia might be reducible. Cough impulse may be present, so you get the patient to cough and you'll see it move and it'll kind of try and reduce itself. You won't be able to get above it. Epididymal cysts, really common, painless. They can be clear. They can be you can kind of struggle to transluminate them, depends what's inside them. You would still send this patient down the 2-week wait pathway most likely, just to rule out a cancer, and they can be excised. Hydrocele will be kind of soft, fluctuant, transluminates. If you find it in an adult, you're thinking a testicular cancer, and you can excise it scrotally by an adult or inguinally for children. In a varicocele, essentially, you get kind of dilation of the vessels in the pampiniform plexus, which essentially causes this bag of worms appearance of the vessels. Tends to occur on the left. If it does occur on the left, we're worrying that there might be a renal cell carcinoma just because of the blood drainage, how the kind of testes drain. It can cause, when you get the dilation of the vessels in the pampiniform plexus, it can because there's a a mass kind of blocking the drainage further up, which would be like a renal cell carcinoma. Balanitis is when we have inflammation of the glands, penis. Tends to be infective due to candida, so you can get some thick white non-urethral discharge. Can be bacterial, so you'll get kind of some yellowy discharge, painful and itchy. Tends to be staph saprophyticus, or anaerobic, which is much less common. Can also be inflammatory, so if you've got any kind of dermatitis or eczema in the area, if you've got lichen planus in the area, or any kind of lichen sclerosis, for example, which are things you'll see in dermatology placement more commonly, or your GP placement, then they can all cause balanitis. Tends to be a clinical diagnosis if you're unsure and you think it might be an infection, you want to target your antibiotics towards something, you can do a swab for MCNS. If you're really unsure and you're struggling with what the underlying pathology is, you can do a biopsy to check for any dermatitis, any lichen planus, any lichen sclerosis. General management includes kind of good washing techniques, so encouraging to use a saline wash and to wash well under the foreskin. If it's causing kind of severe inflammation, then you can use some hydrocortisone cream. And then you treat based on what's causing it. So if it's a yeast infection, so candidiasis, you're using some clotrimazole. Bacterial, flucloxacillin. If it's anaerobic, you can either just use the saline and it'll clear up itself, or metronidazole. And then if it's kind of an inflammatory process, if it's dermatitis, then you're going to use some mild steroids. Lichen sclerosis, you're going to use some high potency steroids. And then paraphimosis and phimosis. So paraphimosis is you're unable to pull the retracted foreskin over the glans penis, whereas phimosis is unable to completely retract the foreskin. So it tends to occur because of kind of a tight constricting band of the foreskin. So that's preventing the retraction of the foreskin over the head of the penis. So that's phimosis. For paraphimosis, you have kind of vascular engorgement of a distal penis. So it can become edematous and then you're unable to kind of replace the foreskin. So some risk factors for paraphimosis specifically is poor hygiene, having it in the past, a catheter, which can cause like edema of the area as well, and having phimosis as well. So it'll present as kind of unable to retract the foreskin, may have happened in the past already. Pain and swelling in the glans penis and the prepuce, that's the bit that sits just below the glans penis. And the management is we need to reduce it as soon as possible. So we give really good analgesia, and then we either use manual pressure, dextrose soaked gauze to draw out the fluid from the penis, or needle puncture. Worst comes to worst, that all fails, then you go straight for emergency circumcision. And after this, you then consider kind of how we're going to, if you haven't done the emergency circumcision, and you've used one of the kind of other methods of reduction, you then think, how am I going to stop this from occurring in the future? And most commonly, that will be kind of an elective circumcision. Okay, so does anyone have any questions before we move on to our gum topic? Okie dokie, let's move on. So in our gum topic, what we're going to cover is all of our causes of discharge, be it STI or non-STI, lesions, so mainly herpes and syphilis, a brief overview of the 5 hepatitis C's that we come across. Just what we won't cover, HPV, because that will be covered more in gynae. Sexual history, again, very gynae. and contraception is covered in CP. So, a 23-year-old woman attends the GUM clinic with vaginal discharge and dysuria. Her partner recently had an STI. What is the most appropriate investigation to confirm the most likely diagnosis? So our answer here is B. So chlamydia is the most common STI in the UK, and we test for that using nucleic acid amplification. So chlamydia is caused by the bacteria Chlamydia trachomatis, and the problem with chlamydia is it tends to lie asymptomatic. So in 50% of men, 70% of women, no symptoms at all. When they do get symptoms, women can get some cervicitis, so some discharge, some bleeding after sex, and dysuria. Men will tend to get dysuria and urethral discharge. The urethral discharge will tend to be mucopurulent, so it won't be like green. It'll be kind of more of a kind of whitish, kind of yellowy or clear discharge, but it'll be kind of abnormal from what they're used to, essentially. So the key kind of investigation to do here is you want to do nucleic acid amplification tests. So for women, you take a swab, so you do a vulvovaginal swab. And in men, you want to do a first void urine sample. So this is different from when you do a midstream. So essentially in midstream, you want them to pee a bit, then you catch the sample. Whereas for men, when you want to do a first void urine sample, you ask them to catch the first kind of bit of urine because that's where the bacteria is going to kind of sit. And it's important with all STIs to consider the incubation period and the time before their test's going to show positive if they do actually have the infection. So for chlamydia, it's 2 weeks. So if a person comes in the day after they've had sex with someone they think might have chlamydia, you can offer them the test, but you can say we're going to have to repeat it in 2 weeks to check again because of the incubation period. So there is a screening for 15 to 24-year-olds. So any 15 to 24-year-old can either order a kit on the NHS website, can go to a GP surgery and request it, go to a pharmacy and request it. And it'll be kind of a self-swab. So the first line is doxycycline for 7 days. We don't do a test of cure for chlamydia. We give the doxy for 7 days, and then we assume that that's kind of got it. If they are pregnant, we just give them azithromycin 1 gram stat rather than the doxycycline. We also have to remind people not to have sex until they've finished their full course of antibiotics, not to have sex with the person who they believe gave them the STI until after they've been tested and treated. So, for example, if it's someone in a relationship, and we have to consider contact tracing as well. So, all women and all asymptomatic men need 6-month contact tracing, and men with symptoms need 4-week contact tracing. But I wouldn't get too bogged down with like the specific contact tracing details. Just to say that you do contact tracing is often enough. Second most common in the UK is gonorrhea. So this is caused by Neisseria gonorrhea. So this appears as gram-negative diplococci. So in a gonorrhea infection, women again will get cervicitis with discharge. The discharge will be kind of more purulent, more of a thicker and green. Lower abdominal pain, and again some inflammation of the cervix, some bleeding after sex. Nature as well, and some dysuria. So this is if we have kind of the infection being in the genitals. We can also get rectal infections in, for example, anal sex or MSM, and pharyngeal infections, which they tend to stay asymptomatic. So it's important to say as well, in men, it can also be a common cause of epididymitis, which is one of the ones we went through earlier. On investigation, what you'll do again is you'll do nucleic acid amplification tests. Again, vulvovaginal swab for women, first void urine sample for men. Testing should be done 3 days after possible exposure. I think now they're pushing it more towards 2 weeks, similar to chlamydia, just because it can incubate up to 10 days in women. It's important to do a culture on anyone who's nucleic acid amplification positive. So the treatment for gonorrhea is a single IM dose of ceftriaxone, oral cefixime, or oral azithromycin as a single dose. And for gonorrhea, we do tested cure. So for contact tracing, we're going to do 2 weeks for men with anal genital, and everyone else, it's 3 months. With gonorrhea, it can then disseminate. So it's more common than chlamydia to disseminate. So when it disseminates, it can present as arthritis. So you'll get like tenosynovitis. So it's can't see, can't pee, can't climb a tree, for example. So it'll also be like dermatitis, tenosynovitis, arthralgia, fever, chills, malaise, kind of feeling quite systemically unwell. And so for that, you want to do blood cultures just to make sure they're not septic. And you want to do culture of whatever organs affected, be it the joints, so the synovial fluid, or skin. And you want to do the nucleic acid amplification as well. And the management, you use the same drugs, but you do it for longer. So you give either ceftriaxone 1 gram IV or IM once daily for 7 days if it's not septic arthritis. If it is septic arthritis, you give it for 14. You also have to drain the area as well for septic arthritis. For Mycoplasma genitalium, so this falls under a category that we call NGU, so non-gonococcal urethritis. So it's becoming more common in the UK. And the issue that we're having with it now is that we used to not really know that this was a thing. We used to just think that all NGUs were chlamydia. So we didn't really know that this was a thing, and therefore it was treated as chlamydia when it wasn't. And now it's gotten to the point where there is quite a high rate of resistance. So it tends to be asymptomatic, but in women you can get again cervicitis with some nuchal purulent discharge, some itching, pelvic discomfort, and it can cause pelvic inflammatory disease. In men, you'll get kind of dysuria, pruritus, nuchal purulent discharge as well. So we again investigate it with our nucleic acid amplification tests. So with women, we do a vaginal or a cervical swab, so it's different from being a vulvovaginal swab. But with men, we still do a first void urine sample. And we do this about 2 weeks after the exposure, similar to chlamydia and gonorrhea. So we test all people with non-gonococcal urethritis, women with PID, people who are actively kind of having sex with people who have NGen, or anyone who's symptomatic with these kind of symptoms as well. And the management for this is we give moxiflox firstly, and or azithromycin one-off initially, followed by a 2 to 3 day course. And then we do contact tracing as standard. For the complications, similar to the other, for chlamydia, it's pelvic inflammatory disease. Similar to gonorrhea, it's epididymal orchitis. and arthritis. But in pregnancy, this can cause preterm birth and miscarriage. So if someone who's pregnant comes in needing an STI screen, it's an important one to test. Next question. So, a 28-year-old woman presents with fishy, thin, grey vaginal discharge, pH of over 4.5 on testing. What's the most appropriate management? Perfect, well done. So, this all kind of screams bacterial vaginosis. So, it's fishy discharge, it's thin, it's kind of got a grey tinge to it, and it's got a high pH. So all this is kind of saying to us this is BV, because when you're thinking this, you're thinking, is it your two kind of differentials here are, is it thrush or is it BV? And this sounds more like a BV picture. So these are our kind of three other causes of discharge, two of which are sexually transmitted, one of which is sexually transmitted and two of which aren't. So BV and vaginal candida are not STIs. Trichomonas vaginalis is an STI. So if we look at BV firstly, it's essentially an overgrowth of Gardnerella vaginalis, which is a natural, naturally occurring in the vaginal kind of flora. When this overgrows, we get a lot of lactobacilli being produced, which raises the pH. This can tend to occur when you've used, for example, a new soap, or a new detergent, or you've had a new sexual partner. So, as the question stem previous said, so we have this fishy discharge. It's thin, it's homogeneous, high pH, so over 4.5, fishy odor to it. And when you do microscopy, so you can take a swab of this and look at it under the microscope. When you have your sexual health placements, you'll see this quite a lot. They just do a swab and take it straight to look under the microscope. And you'll see clue cells, which look like this. So clue cells, so if you look at this one here on the trichomoniasis one, this big cell here, that's just a normal kind of vaginal epithelial cell. Whereas on the bacterial vaginosis slide, you can see that they're like peppered with these like black dots surrounding it. And that's actually the bacteria sat around the vaginal epithelial cells. And we call these clue cells. And so the treatment for this, correctly, as you said, is oral metronidazole. But it does tend to relapse, so you can have to have multiple courses of metronidazole to get this to fully clear up. And you give supportive management as well. So you let women know that this can occur with a new sexual partner. You advise against using kind of harsh soaps down in that area. And then our other non-STI cause of discharge here is vaginal candida. So candida can occur again for many different reasons: new soaps, new detergents, new sexual partner. It can also occur when you've got other risk factors such as diabetes, especially uncontrolled or poorly controlled, pregnancy, immunosuppressed, be that HIV, steroids, or you just use antibiotics. And so the difference between BV and vaginal candida is that in candida, you get this really thick cottage cheese-like discharge, which is non-offensive, doesn't really have a smell to it. And if this discharge kind of sits in the area for a while, it can then cause some itching, some redness, it can cause some fissuring, or it can cause some vulvitis. So it can cause superficial dyspareunia. So this is kind of pain during intercourse that occurs superficially rather than kind of on deep penetration, and some dysuria as well. Tends to be a clinical diagnosis, and you have a couple of options. If the person would prefer a topical agent, or if they're pregnant, you give them a cream or a pessary. if they're able to tolerate oral antifungal agents, then you give them either itraconazole or fluconazole. Trichomoniasis, Trichomonas vaginalis is an STI. It's much less common than the other ones that we've looked at. It causes a frothy kind of yellowy discharge. Vulvar vaginitis, so similar symptoms to Candida, so dyspareunia, dysuria, itching. Rarely it can cause strawberry cervix, so it's a really red cervix with what looks like they look like seeds essentially, but what they actually are is the parasite being sat on the outside of the cervix. So you'll take a swab of this um and do a wet mount, and you'll see these kind of motile trophozoites, which you'll see here. So we can see that they have flagella because they're parasites. Um, and so what we do with these is we give metronidazole. Just a quick note on BV and Candida. So BV in pregnancy does increase the risk of preterm labor, low birth weight choriamnitis, late miscarriage. So it's really important to treat it. And if a person's having recurrent candidiasis, important to check that they took the medicine, important to check for diabetes, HIV, exclude any differentials like lichen sclerosis. So that's a kind of can be a precancerous condition. And if you've ruled all of this out and it's just that they're having recurrent vaginal candidiasis for no clear reason, then you can give fluconazole kind of induction and then maintenance therapy. Moving on to look at herpes now. So tends to be HSV1 or HSV2. And it occurs due to direct contact with lesions. So you'll initially get painful blisters on the external genitalia, which then burst. You can also get some dysuria and feel systemically unwell, which can last for kind of up to 20 days until they kind of heal over. If you then kind of fall ill, have like a weakened immune system, you can then get recurrent episodes, which tend to be at the same site, and you'll get a bit of a burning feeling, kind of similar to what you get with shingles. You then investigate that. You can do a swab at the base of the ulcer. You can do a PCR for the HSV or a culture, more common to do the PCR. And then you can give some management. So conservative initially. So really important to get a good level of pain relief on board. So a saline bathing can reduce the pain, or analgesia, topical lidocaine. And then with the initial episode, you treat that. So you give oral acyclovir for 5 to 10 days, depending on how long the lesions stay. And then for recurrent episodes, you can either give episodic treatment, so when they actually flare up, or if they get really common, like attacks or more than 6 a year, then you can give a long course of antivirals for up to a year. HSV in pregnancy will only occur if the baby comes into contact with active lesions during birth. If they do, it can cause localized disease, CNS disease, or a disseminated infection. If someone has a primary attack after 20 weeks gestation, you're going to go straight for a C-section. If they have recurrent herpes, you're going to treat with suppressive therapy. So they're going to be an antiviral during pregnancy, and therefore the transmission will be really low. So we've now got a 33-year-old man presenting with a widespread maculopapular rash, including his hands and soles, along with a headache and a lump in his groin. 6 weeks ago, he had a solitary painless ulcer on his penis. What is the most likely diagnosis? Brilliant. Yeah. So this is B. So there's three distinct stages to syphilis. So just to say, syphilis is what we call treponema pallidum. Um, so we have early and late stages. So our early stages are first and second stage. So the first stage essentially is a painless ulcer at the contact of where the sex occurred. It can be kind of externally on the vulva, on the penis. It can be deeper, it can be on the cervix. It can be, if it was oral sex, it can be in the mouth. And you can get some kind of lymphadenopathy, which is not painful and it's localized to where the ulcer is. 6 to 10 weeks later, you then feel generally unwell. You get a bit of a rash, maculopapular rash, fever, lymphadenopathy. You can get these snail track ulcers, which we'll see a picture of on the next slide. And then if it's kind of left for over 2 years, it can then kind of go disseminated and cause quite a lot of problems. So we can have gummatous syphilis, so you'll get these lesions in the bones. You can get cardiovascular syphilis, so aortic aneurysms, heart failure, aortic regurg, or neurosyphilis. So there's been a big increase of neurosyphilis in the UK in the last kind of couple of years because people aren't being tested for syphilis and therefore it goes untreated until it becomes tertiary. So there's a few different signs you can get when you get neurosyphilis, as we'll see on the next slide. So this is a picture of a chancre. So a chancre is another name for that painless ulcer. So this person has a chancre on the mouth. So that was where the site of the sexual contact was. Secondary, that's a maculopapular rash and our snail track ulcers, you can see here. And this is a gummatous lesion. So it's got a granuloma, which is caused by the syphilis. Argyll-Robertson pupil, kind of hallmark of this is that they won't dilate to light, but they will dilate to accommodation. And Tabes dorsalis. So Tabes dorsalis essentially affects the dorsal columns of the spinal cord, and because of that, you lose vibration and position sense below the level of wherever the syphilis has set up camp, essentially. So some investigations that you can do in syphilis, there's two key types of investigation we do. There's non-treponemal and treponemal. So the non-treponemal ones aren't specific to syphilis. They can be high or positive in a lot of conditions, including lupus, TB, malaria, HIV, antiphospholipid pregnancy. The key kind of thing with this is it's more used to check that it's been cleared, the syphilis has been cleared, and to check that there's a response to treatment. Whereas the treponemal specific tests, they are obviously specific to treponema, so they'll become positive when you have syphilis, but they'll stay positive even after you've been treated for it because it is an antibody test. So if both of these are positive, you're pretty convinced that this is syphilis. If the non-treponemal one's positive, but our treponemal one's negative, then you're thinking it's a false positive for one of these reasons. If this one's positive, our treponemal's positive, and our non-treponemal's negative, then we're thinking this person's been adequately treated for syphilis. And if both are negative, we're thinking that they don't have syphilis. So our first line management is we give IM benpen or oral doxycycline for 14 days, just in case they don't want an IM medicine. The thing that can occur when you treat syphilis is something called a Jarisch-Herxheimer reaction. And so this can look a little bit like anaphylaxis in the sense that you'll get a rash, a fever, some tachycardia, but you won't get the wheeze or hypertension with anaphylaxis. And this is just toxins within the bacteria being released as the bacteria is killed. And so you just manage this really supportively. So you just give some antipyretics, encourage oral fluids. So that's if we have primary or secondary syphilis. If we have tertiary syphilis, we have to give kind of more frequent doses of the benpen. So if you've got cardiovascular gummatous disease, once a week for 3 weeks. Neurosyphilis, we have to move to Pen-G. And we can use those non-treponemal tests to see how well the person's responding. So we're looking for a fourfold decline. So the non-treponemal tests are a little bit weird when you try and interpret them. So essentially the bigger the number, the bigger the right-hand number, the better, like the less bacteria there is, because this is essentially saying you have to dilute to 1 in 16 to not see any more bacteria, whereas this one you only have to dilute to 1 in 4 to not see the bacteria anymore. So we have to test for syphilis 90 days after contact because it can take up to 3 months for the test to go positive. And when we do partner notification, we do in the last 3 months if it's primary and 2 years if it's secondary. And so syphilis is one of the tests that is done in booking a pregnancy. If it's found to be positive, we can give IM benpen. But if we don't treat it, it can cause congenital syphilis. So there's a lot of characteristic signs you'll see. So these are Hutchinson teeth. So they have like they look like a W. Saddle nose, and saber shins. So the shins have a bit of a curve to them. You also get keratitis, deafness, and scarring in the angle of the mouth. And we're just going to go through some very briefly, some HIV, some hepatitis, so before we go through our HIV. So if we look at A firstly, A and E, because they kind of have quite similar kind of morphology. So A and E are both transmitted via the fecal oral route. And they incubate for 2 to 4 weeks for A and 3 to 8 weeks for E. You also get the characteristic symptoms along with all the kind of hepatitis, other hepatitis, anorexia, jaundice, dark urine, vomiting for E. And for both, supportive management is key. So for E, there's no vaccine available. For A, you would want to vaccinate household contacts or other kind of contacts as well. And vaccinations available if you're going to endemic areas or you're at high risk of transmission. A, it's very rarely any complications, but E, we tend to worry about in pregnancy because there's a high mortality in pregnancy from Hep E. Hep B occurs due to either parenteral or sexual contact, and we treat that through either using pegylated interferon A. There's been a bit of a move away from that now using other antivirals, ones that we tend to use more in HIV, such as tenofovir. And Hep C, parenteral route. So we worry about this more in IV drug users specifically. We check the RNA for this, and we give protease inhibitors and ribavirin for Hep C. There's no vaccine available for Hep C, but there is for Hep B. And for both Hep B and C, chronic kind of hepatitis, liver failure, HCC, cryoglobulinemia are all really kind of complications for this. In Hep C, you can also develop Sjogren's as well. And Hep D only occurs if you've got Hep B, and we call it a superinfection. So if you've got Hep B and you get infected with Hep D, then you're more likely to have kind of chronic hepatitis, cirrhosis, HCC. So we do PCR in a similar kind of mechanism to how we treat Hep B. So a nurse attends an occupational health appointment to check if her Hep B vaccinations are up to date. Which of the following serology results is in keeping with previous vaccination? Brilliant. Yeah. So our answer here is C. So if we look at how we're going to interpret our serology, the first thing I always look at is the HB surface antigen. So that is going to tell us if we've ever had an infection. So in both acute and chronic Hep B, that's going to be positive. I then look to see if anti-HBC is positive. Because if that is positive, then that's going to, and if it's, depending if it's IgM or IgG, that's going to tell us if it's acute or chronic. So chronic is going to be more IgG, as we can see our IgG occurs and persists, whereas our IgM drops off after kind of 6 to 8 weeks. And then I look at the anti-HBS. So that's going to tell us whether we're immune at all. So naturally immune will be positive, as will vaccinated people. So vaccinated people will have just anti-HBS positive. They won't have anti-HBC, so HB core antigen antibody, because they haven't been exposed to the core antigen to be developing a core antibody. For Hep C, we initially test the antibody. If it's negative, they haven't had an infection within 3 to 6 months. If it's positive, we then move to either antigen testing or PCR. If that's negative, they've had no infection in the last 2 to 4 weeks. And if it's positive, then we're happy that there's a current Hep C infection. The reason we do this is because the Hep C antibody persists even after correct treatment, adequate treatment. And so we then move to test the antigen or do the PCR to check for active infection. So Hep B vaccination is offered on the immunisation schedule now in the UK. It's also offered to at-risk groups, so sex workers, healthcare workers, IVDU, close family contacts, for example. We give 3 doses. Some people can struggle to form a reaction, immune reaction to it, 10 to 15%. And we check levels after 1 to 4 months. Hep A is offered to people traveling to endemic areas, people at high risk of fecal oral transmission, so many have sex with men, people who inject drugs, or with underlying kind of conditions which would put them at an increased risk of complications from Hep A. So chronic liver disease, haemophilia, or people who are high risk of fecal oral route in occupation, so lab workers, sewage workers. Hep B, similar to syphilis, is also part of booking tests for pregnancy. If it's found to be positive, then they need to complete a complete course of vaccination, and for the baby, and also they'll need some Hep B immunoglobulin. So if the mum has chronic Hep B, the baby's going to need the full accelerated course of vaccination and Hep B immunoglobulins. And if they have been born to a mother who's had an acute Hep B during pregnancy, they'll also need the accelerated vaccination course and immunoglobulins. And it's important to say that Hep B cannot be transmitted through breastfeeding, so the woman's safe to breastfeed even if she has had an active Hep B during pregnancy or has chronic Hep B. Okay, there's a quick feedback. We've still got HIV to come. And there's just a quick feedback link there. If you want to scan it now, that it's also repeated at the end of the presentation as well. It's just if you prefer to fill it out kind of now as we're talking about HIV. Give you kind of a couple of seconds to get that if you want it. Okay, brilliant. We move on to HIV. So we're going to go over how HIV kind of infection occurs and its stages. how we test and counsel for people, PEP and PrEP, retroviral therapy, and opportunistic infections, and a little bit on HIV and pregnancy. So we have the initial infection of HIV, and when that initial infection occurs, the CD4 count starts to drop off, tends to occur between 3 to 12 weeks, and the RNA in the blood increases for the HIV. And when this increases and the CD4 decreases, that's when we get our what we call seroconversion phase. So it can be asymptomatic. It can also be really non-specific symptoms such as sore throat, lymphadenopathy, malaise, myalgia, just kind of very non-specific kind of flu-like illness. And at this point, because their viral load is so high, they're very infectious. But then after that, we go through kind of a latency period. So the CD4 count can recover and the viral load drops off. And then they live asymptomatically for a long period of time, kind of 10 to 15 years, and then gets to a point where their CD4 count drops to the point where they start to get these opportunistic infections and what we call AIDS defining illnesses. And so we define AIDS as a CD4 count of under 200. So we can offer HIV testing to people at high risk of exposure, so sex workers, people who inject drugs, men who have sex with men and their female partners, people from countries of high HIV prevalence. We can offer it to people attending health services such as sexual health services, TB and hepatitis clinics, antenatal clinics. Again, it's one of our booking tests. And in London specifically, because of such a high prevalence of HIV, people accessing healthcare in London get HIV testing as kind of, it has to be an opt-out scheme. And we can offer it to people who've just had a sexual partner recently diagnosed and those who have symptoms. So we go through a system called REBA to kind of counsel people on a HIV test. So initially we'd figure out the reason they need testing. Is it because the patient themselves has asked for it? Is it because they're at high risk? Is it because they've got a red flag such as they've had like seroconversion illness or potentially an AIDS defining illness? You do a good past medical history and social sexual history. You then go to E, so have they ever tested before? So if so, what was the result? Why did they have the test? The next E is exposure in the window period. So you have to explain the window period to them. So we'll go through this in a bit more detail when we look at the type of testing. But essentially, you're going to have to do another test. If you test them early, you're going to have to test them at 12 weeks after the potential exposure anyway. So you have to cancel them on the fact that if we're doing the test early, you're going to need it repeating in 12 weeks anyway, the 12 weeks after exposure anyway. And then you decide whether they want a point of care test, which we'll go through, or the P24 and antibody test. You explain the benefits of testing. So you get to identify positive people, other people with positive HIV, and you explain that that's a normal life expectancy, prevents transmission, take medication, and you give the basics on how the test will be taken. So there's two tests, venous or point of care. So venous sample tests for two things, the P24 antigen, which stays positive for the first 4 weeks after the infection, and the HIV antibody test, which will stay positive, which can take up to 12 weeks to go positive, but when it does go positive, it will stay positive. So that's the venous test, and so we tend to wait up to 12 weeks after the exposure to do that. And point of care test depends on what they're using. It's essentially a blood pinprick finger prick test. You'll get the results straight away, but if it comes positive, you then have to go straight for the venous sample afterwards to confirm that. And then you get verbal consent. So we have a 20-year-old man presenting to a GUM clinic 4 weeks after having undetected sex with another man. He's worried he may have caught HIV. What's the most appropriate diagnostic test to provide an accurate diagnosis? Brilliant, yeah, so our answer is D. So, antigen antibody test is used for diagnosis and screening. Our rapid point of care test we can offer if provided that they are in the 3-month window period, so you have to wait for 3 weeks. And then viral PCR is more to look at vertical transmission to check their viral load, and whether there's high risk of transmission from mother to child. So we have a combination test in the UK. So we do HIV P24 antigen and a HIV antibody. We use it for diagnosis and for screening. We can also test the RNA levels, also known as the viral load, at the same time. So HIV antibodies, it can take up to 3 months to go positive, essentially. So it cannot be positive in early infection, but will go after 3 months. For the P24 antigen, we're looking at this core protein within the HIV, which will only stay positive for up to 4 weeks. If this cause positive, you repeat it straight away to check. If you use a point of care test, you have to do this test anyway to confirm it. So if the person comes after kind of 4 weeks and thinks they've had an exposure to HIV, then you test them. If it's positive, you have to repeat it straight away just to confirm. If it's negative, you have to explain that, okay, it's negative now, but it can take up to 12 weeks for especially the antibody to show positive. So we'd have to repeat it in like 8 weeks. So it's 12 weeks post-exposure. So if we look a little bit at PEP and PrEP now, so starting with PrEP, so pre-exposure prophylaxis, so this is to prevent people at high risk of developing HIV from contracting it. So it's offered to kind of men who have sex with men and trans men and women who are having condomless anal sex. HIV negative partners to HIV positive people and other people at high risk. So in the UK, it's Truvada. You don't need to know that. That official name, just need to know that it is pre-exposure. And the 2 key tests to do is before initiating it, you want to make sure they don't have HIV before you give it, because this is kind of 2 of the drugs that are used to treat HIV. So you don't want to be giving it to them as PrEP when they have HIV, because you'll want to add another one in to treat them for HIV. And you also want to check using these just because Truvada can be a little bit toxic to the kidneys. And then you want to do HIV testing 3 monthly when they're on PrEP, just to make sure. And you also have to counsel them on the fact that yes, it has good prevention from HIV, but doesn't prevent you from other STIs. So you do other STI checking kind of 3 monthly, especially if they're engaging in condomless sex. So I'd say the 2 key ones to know here that I've come across the most are event-based PrEP and daily PrEP. So these are the 2 that I've seen talked about in sexual health clinics. Event-based PrEP, you take 2 pills 2 to 24 hours before the sex, 1 pill 24 hours later, and another pill another 24 hours later. And if you're having kind of repeated sex, you have to keep taking the 1 24 hours later, until you've had 2 sex-free days. With daily PrEP, you just take 1 tablet once a day, not kind of event-based at all. There's these other options, which are kind of 4 pills a week, or you take it specifically while you're on holiday and expecting to have condomless sex. Post-exposure prophylaxis is offered when someone's had kind of receptive anal sex. So receptive anal sex is a higher risk for developing HIV than insertive anal sex. So if they've had receptive anal sex when you don't know the person's HIV status or you don't know they're positive, or with a HIV positive partner of unknown viral load, then you offer it. You also, if they are a high occupational exposure, or someone who's injecting drugs with someone who's HIV positive. You can consider it if they've had inserted vaginal sex or inserted anal sex when you don't know the HIV status or HIV load. But if you've got like a Sharp's injury, insertive vaginal sex from someone with unknown HIV status, or a bite from someone who's HIV positive, you don't need to recommend it. I would probably learn these ones as the first ones to learn, the routinely offered ones. So it should be started within 72 hours of exposure. In an ideal world, it would be 24 hours within 24 hours of exposure. You choose 3 drugs from 2 different classes. You don't need to know the names of the drugs, and you don't need to know the classes. That was one thing that we were told repeatedly last year. You do some baseline tests, so you test their HIV status prior to initiating the PEP. You also do use an ALT, just because some of the drugs you use can be kind of renal toxic, toxic. You want to check their Hep B serology as well, because if they're at high risk of HIV, they're probably at high risk of Hep B as well. If it's a sexual exposure, you want to do STI testing as well. If it's Hep C screening, if it's a man who has sex with men, well, men who have sex with men with a sexual exposure. So you give them the PEP, ideally within 24 hours of the exposure, and you say, we're doing a HIV test now, but we're also going to have to do one in 45 days after you've completed the course to check that you haven't developed HIV in the meantime. Obviously, if they show positive on the first test, you're just not going to bother with PEP, you're going to go straight to treating them for HIV. So we now have a 26-year-old man presented to the GUM clinic to discuss the results of his HIV test, which has come back positive. What's the most appropriate management? Well, yeah, so our answer is E. So we initiate antiretroviral therapy immediately when someone's tested positive for HIV. We don't wait until the CD4 count drops. This person's tested positive, so we don't offer PEP. And nucleoside receptor, I can't remember the rest of it. But this is one of the class of drugs. This is just one drug. We don't give one drug in HIV. We give 3 drugs from 2 different classes. So these are all the different types of drugs and drug types that we have for HIV. This isn't to say you need to know any of them, because you don't need to know the classes, you don't need to know the names of any specific ones. This is just to show that we have lots of different options at targeting HIV. We target it at multiple different levels. So, for example, we can give a nucleoside reverse transcriptase inhibitor, that's the name I was looking for, and either a protease inhibitor or a non-nucleoside reversed. So I've got a question. Don't they look at sensitivities first after testing positive? So nowadays I think they do. However, in kind of AKT land, you just say that you'd start antiretroviral therapy. It also depends on whether the patient can tolerate certain ones, because some of the ones they cause a lot of quite serious side effects, and they're quite poorly tolerated. And also depending on how their renal and liver function comes out can dictate. So they can look at sensitivities. I think nowadays it's kind of best practice that they do. But they tend to look more at sensitivities if you've been on antiretroviral therapy and then stop it for, or are like really inconsistent with taking it, or you stop it for a while and then want to restart it, because it's a good likelihood that it's then become resistant during the meantime. So we're now going to look at some opportunistic infections and some AIDS-defining illnesses. So the first one here isn't actually an AIDS-defining illness, because our AIDS-defining illnesses only occur under 200, CD4 count 200. So oral hairy leukoplakia. So we get EBV virus on the tongue, and it looks a bit like oral candidiasis. And the difference between that and oral candidiasis is the fact that with candidiasis you can kind of scrape off the white stuff, whereas with oral hairy leukoplakia you can't. Very self-limiting. Don't need to do anything about it. The most common opportunity infection in AIDS is PCP, so pneumocystis cerevisiae pneumonia. So classical kind of questions then for this will be like, they desaturate when they exercise, so they get out of bed and suddenly they desaturate. So you can get typical pneumonia symptoms, so dyspnea, dry cough. The chest often does sound clear though. You do a chest x-ray and you'll see pulmonary infiltrates, exercise-induced desaturation, as we said. And you'll do a silver stain on it. You'll culture it essentially, try to culture it, and you'll do it under the microscope. You'll add silver stain and you'll see some cysts. And that will tell you that you've got PCP. And so you give cotrimoxazole in this case. Nowadays, if the CD4 count drops below 200, we give cotrimoxazole as prophylaxis, because it's so common in people with a CD4 count of under 200 that we try and prevent it with prophylactic cotrimoxazole. As we drop down to kind of 50 to 100 CD4 count, we can develop aspergillosis. So it causes multi-organ disease. It often causes lung disease though, and we have to treat this with antifungals. And we can get Mycobacterium avium complex. And so you get kind of persistent cough, weight loss, hemoptysis, and you have to give a long course of antibiotics. And you tend to get that when your CD4 count drops below 50 specifically. In the GI tract, you can get oral thrush. So as we saw previous, you don't have to have HIV to get oral thrush, really common, but it tends to occur when you have HIV and your CD4 count tends to drop. We treat this kind of more persistently than we treat a non-HIV patient, so we give fluconazole for 7 days, advise on dental treatment as well. Cryptosporidiosis is when we essentially have cryptosporidium in the GI tract, and it causes really watery diarrhea, some abdominal cramps, can cause pancreatitis as well. We take a sample and we look at under the microscope with a Zeal-Nielsen stain, and we see these red cysts, which we can see up top here. Antiretroviral therapy does tend to help this, but if not, then we can give nitazoxanide as treatment. And we can get, similar how we get oral candidiasis, we can get esophageal candidiasis, and this occurs when the CD4 count drops to 50 to 100. And this will present as dysphagia and odynophagia, so pain on kind of swallowing and struggling to swallow. You have to give fluconazole for this, or itraconazole. Initially oral. If they can't tolerate oral, you then go to IV. Looking at our neurological conditions now, you can get cerebral toxoplasmosis. So you'll get headache, confusion, drowsiness, typical kind of neurological space enhancing kind of symptoms. And here you'll see that you get a ring enhancing lesion here with some mass effect. So you can get midline shift, you can get kind of general edema. You treat this with sulfadiazine and pyrimethamine for about 6 weeks, and then you lower them off it onto a lower dose for chronic maintenance. And then 2 weeks after treatment, you start them on antiretroviral treatment. You also have multiple progressive multifocal leukoencephalopathy. Essentially, you get a JC virus, kind of superinfection, which causes demyelination, can cause speech, motor, behavioral changes. You do MRI, which shows demyelinating white matter, and there's not really much you can do for that. You just have to make sure they're on optimal ART therapy. Cryptococcal meningitis will occur at a CD4 count of about 50 to 100. You'll get your typical meningitis symptoms, and you'll do a lumbar puncture. You'll get high opening pressure, just because it's fungal infection, and then you'll have a look under the microscope with India ink, and it'll be positive, and this is what you'll see here. So for this, you initially give IV amphotericin B and oral flucytosine, and then you get them onto fluconazole long term for over a year. Primary CNS lymphoma occurs if the person's got EBV as well. It can cause confusion, memory loss, aphasia, seizures. You'll see either one or multiple homogeneous enhancing lesions. So it won't be ring enhancing, the whole thing will enhance. And for that, you give steroids to reduce the kind of edema in the brain, and then you'd give either whole brain radiation or chemo. Looking at the skin now, so shingles obviously occurs in a lot of people that don't have HIV, but it's more likely to occur if you do. You'll get the burning of the dermatome, a macular then vesicular rash. You give antivirals, so I believe it's ganciclovir for shingles. Kaposi sarcoma is a tumor due to the human herpes virus 8. You get these kind of typical nodules that are purple. They can occur on the skin. They can also occur in the lungs, lymph nodes, GI tract. You can biopsy them and do a CT to check any lymph nodes. And you want to initiate them on antiretroviral therapy. If this works and it kind of lessens them, then great. If not, you might have to inject them with vinblastine, which is a chemotherapy agent, or radiotherapy. You can also get in the eye something called CMV retinitis. So this is when you have a CD4 count under 50. You essentially get blurred vision. You do the fundoscopy and you'll see areas of hemorrhage and necrosis. It's called a pizza pie retina, and you give ganciclovir here. When you start antiretroviral therapy and the person's got another infection on board, such as EBV, it can cause like a mass inflammatory response, which may need steroids, but you also need to try and treat the underlying infection. So, for example, if you've got EBV because you had oral hairy leukoplakia or CNS lymphoma, and then you start them on antiretroviral therapy before you've adequately treated the infection, then you can cause iris immune reconstitution inflammatory syndrome. Occurs more likely when you have cryptococcal disease or TB meningitis. When a person has TB, also important to think about HIV as well. They tend to go hand in hand. So HIV is a really strong risk factor from having kind of isolated kind of pulmonary TB into disseminated. And you treat normally like you treat TB. So with your rifampicin, isoniazid, pyroxidine, pyrazinamide, and ethambutol. You want to start ART 2 weeks after starting your TB treatment if the CD4 count is under 50, 8 to 12 weeks if it's over 50, because we don't want to prevent that immune mass kind of immune storm from occurring. You can start it earlier, like when the CD4 count is under 50, because they're struggling to mount an immune response to begin with. Whereas when their CD4 count's over 50, they're mounting a relatively adequate immune response, and so have the ability to kind of have immune reconstitution inflammatory syndrome. In pregnancy, it's a booking test. If they test positive, you offer antiretroviral therapy to all pregnant women. If their viral load at 36 weeks is under 50 copies per mil, you can consider vaginal delivery. Over 50, then you have to do a C-section, and you have to give a azidovirine infusion before starting the C-section. And if the viral load's over 50, you have to give triple ART to the baby. The viral load's under 50, you can just give them oral azidovirine. HIV is different to Hep B. Hep B can't be transmitted in breast milk. HIV can, so all HIV patients cannot breastfeed. Exposure-prone procedures. So clinicians with HIV, they have to be under an occupational health consultant, HIV physician, have 2 viral load tests 3 months apart, both of which have under 200 copies per mil, and have 3 monthly viral load monitoring. And they're on a special register, occupational health register. If they fail to adhere to this, then they're not able to do exposure-prone procedures. The occupational health consultant can inform the healthcare workers manager without their consent if they refuse to attend regular tests or have a viral load of over 1,000. Key things with ART. So you don't need to know the names, you don't need to know the classes, but do not start, stop, or change ART therapy without speaking to a HIV consultant. And if you're prescribing anything, go on the University of Liverpool HIV drug interaction website and check to make sure there's no interactions with the drugs prior to prescribing. And U equals U. So this is a really popular public message at the moment, and has been for the last few years. So if you have an undetectable viral load, it means you cannot transmit HIV even during condomless sex. So that's everything for today. Does anyone have any questions before we finish? There's a feedback, the same feedback QR code there as well. Great, so if no one has any, do we have a question? No, brilliant. Thank you so much for coming. So yeah, the next session is this time, well, 6 o'clock next week, for dermatology and ophthalmology. So brilliant, thank you very much.